Hi everyone, we're super excited to be joined by Dr. Dij today to cover restoring root-filled teeth. Dr. Dij is all about high-quality endodontic treatment and has a massive passion for teaching. His work has led up to Evo Endo, an endodontic clinic for referring dentists and a center for endodontic learning for early career dentists. Thank you for coming on to the show, Dr. Dij.
Thank you so much, though. Looking forward to it.
So let's get started. Now, what are the aims of restoring root-treated teeth?
I think fundamentally when you're looking at restoring a root-filled tooth, you want to preserve as much tooth structure as you possibly can. You want to predictably ensure that you've got a good seal and prevent reinfection of the root canal system. And furthermore, make sure that you understand the substrates that you're bonding onto, i.e. enamel, dentine, what type of dentine do you have, to achieve a predictable end result.
And once we have this root-treated tooth, how should we go about our evaluation?
Fundamentally for you guys, I believe in keeping things simple. So I like to break things down into four main things, which is an endodontic evaluation, which as an endodontist is what I always look at first. Periodontal evaluation, biomechanical status of the tooth, and aesthetic evaluation. And if we can combine those four principles, we can then try and get a predictable outcome for our patients.
And how would you carry out your endodontic evaluation?
Really good question. I guess the importance with endo comes from making sure you have a predictable end restoration. If you haven't got a predictable base from which to work to, you're going to come across problems. What is a predictable base or predictable endo evaluation for me? The tooth should be free of any signs of apical pathosis on a radiograph, and also obviously missing any clinical signs and symptoms of any inflammation or any signs of infection that are there.
And how about your periodontal assessment?
Periodontal assessment, I fundamentally like to break it down. Looking at the gingivae, with the gingivae, we're looking at healthy probing depths of 2 to 3 millimeters around the tooth, also assessing the bone levels around the tooth, okay? We all know we want adequate bony support around our teeth. Also, as well as that, maintenance of the biological width and ensuring that we have an adequate ferrule around the tooth. I also look at is crown to root ratios, okay? I like to make sure that there's plenty of root supporting any restoration that I'm placing on top.
And how about your biomechanical evaluation?
Biomechanical evaluation is looking at how much tooth structure I have left and what forces are going on top. And if I can predictably restore a tooth, understanding the forces that are going to be applied, as well as how much tooth I have left, I'm a happy man.
And what do you look at in terms of aesthetics?
Aesthetics? Look, I think aesthetics comes down to one thing and one thing only, which is matching your patient's expectations. Just make sure that you understand what the patient expects of you and not what you want to do.
And Dr. Dij, I know you have a golden rule. Can you explain it, and does it apply in 100% of cases?
Yes. The golden rule is simple. It's the quality and quantity of tooth structure that governs the success of a restoration in the long term, rather than thinking about what restorative material I'm working with.
And can you talk a little bit about what is a successful restoration in your opinion and the importance of the ferrule?
Oh, really good question. So for me, a successful restoration fundamentally is a restoration that lasts. And I want to have the confidence to tell my patient that this will predictably be in their mouth for 5 years. Okay. What we talked about earlier about the pre-treatment evaluations helps me understand and communicate to my patient what my expectations are as to how long a restoration will last. A successful restoration is one that is in function and is asymptomatic and the patient is aesthetically happy with. That will lead to a good end outcome for both you and your patient. The ferrule effect is fundamentally described as a band that encircles the perimeter of a tooth, and it is very important because it imparts fracture resistance to a tooth, because teeth, and particularly posterior teeth, are very good at taking compressive load, but taking non-axial loading, not so great. And the ferrule effect provides resistance to these lateral forces.
And you briefly touched on it before, but can we talk a little bit more about the importance of that crown to root ratio?
Yes, crown to root ratios. Fundamentally, I'm looking at how much root do I have that's going to support my restoration on top. How do I assess this? I'll normally look at the level of the alveolar crest on a radiograph, and then what is beneath the alveolar crest is my root ratio, and what is above the alveolar crest, in my mind, is my crown ratio. And from there, we know that ideally a 1-to-1 ratio is what we require as a minimum. because otherwise you are going to potentially unfavorably load that tooth and have adverse outcomes.
And other than the crown to root ratio and the ferrule, are there any other things that we need to be considering as well?
Like I mentioned, as well as considering how much tooth structure you have left, you also have to think about the forces that are applied on the tooth. Tooth position, okay, is fundamentally important because we know that posterior teeth behave very differently to anterior teeth when it comes to the load that they're taking. And already mentioned then, occlusal forces, we would always treat a parafunctional patient very different to a patient that hasn't got any parafunctional behavior. And knowing that beforehand is planning, whereas realizing it afterwards is planning for failure.
And I know we spoke a little bit about the patient expectation when it comes to aesthetics, but is there anything as dentists we should worry about when treating root-filled teeth?
Yeah, again, very good questions though. For me, I think you have to pay particular attention to where you're removing the GP up to, particularly in anterior teeth. As we know, patients have a very high expectation of teeth that are in the aesthetic zone. And if we leave our GP too high, then that could cause discoloration of the tooth. I always ensure that the GP is cut 2 millimeters below the CEJ.
And now, in terms of treatment strategy, can you discuss the new classification for root-filled teeth restorations?
Yeah, there was a useful paper that was recently released. There's many classifications that you can use, but one from Zaro et al. Classified it into when you wouldn't use posts. So the best post is no post. Okay, so class 0, as they describe it, would be no post. Class 1 is the use of a fiber post. Class 2 is when you would need crown lengthening or orthodontic extrusion, because when you do not have a ferrule, you have to plan for a ferrule or make a ferrule. Class 3 is a cast post, and then also understanding when treatment isn't predictable and communicating that with your patient. And sometimes actually treatment might not be feasible. And class 4 is, well, it might be better in this case, take the tooth out.
And what are some of the treatment options that you would give for an anterior tooth?
With regards to root-filled teeth, I think it fundamentally comes down to assessing how much tooth you actually have left. So for anterior teeth, what I'm looking at is how much tooth structure I have left. I follow the golden rule, as I call it, that quality and quantity of tooth structure govern success. So the more tooth I have, the less likely I am to place a post within the tooth. How much, or when do I start thinking I might need a post? Less than 50% of tooth structure remaining, or 2 or fewer wards of the tooth remaining. Only place a fiber post if a tooth has a ferrule. Otherwise, that post will be unfavorably loaded and is likely to debond. And it was an old story and an old conversation, what's better, cast or fiber, cast or fiber? My answer is treat the tooth. Every tooth is different. The tooth will tell you its story. I prefer to use fiber posts when the opportunity allows. When the canal shape doesn't enable me to predictably bond in a fiber post, I may consider putting a cast post within the tooth. However, with cast posts, we know they're stiff posts. Because they're really, really stiff, you have to also sometimes inform your patients about ways in which teeth can fail. And with rigid posts, they concentrate stress, and you're likely to get a root fracture with a cast post over time rather than a fiber post. A fiber post is more likely to debond. So those are the sorts of things you would look at, but fundamentally for me, the first answer would always be no post. And then if I need to, fiber post if I have a ferrule. If you're gonna place a cast post, I know I've said this in the past, but it's the final nail in the coffin, because the patient then understands when and if this tooth fails, there is nothing more that can be done.
Perfect. And how about a posterior tooth?
Posterior teeth you can treat very differently. For me, though, posterior teeth have a larger surface area to bond to. So again, if we've got a larger surface area to bond to, for me, what that means is I'm not thinking about placing posts unless I really need to, because we take advantage of the canal orifices and the shape and anatomy of the pulp chamber, if we needed to make sure we can predictably bond to that. So again, for me, if I don't need to place a post, I won't place the post. The only time I'm thinking about a post is when I have literally hardly got any coronal tooth structure left. And firstly, I'd prefer to bond rather than place a cast post.
And we talked about this a little bit before, but what does the perfect post look like?
You know, another passion of mine is biomimetic dentistry. So I would turn around and say the perfect post is no post. And if you actually are going to do a post, make sure it is planned. Make sure it's a passive fit and you're not removing excessive amounts of dentine. So just preserve as much dentine as you can. And when you're placing a post, a good paper was from Ricketts et al. That in 2005 that described the ideal properties of a post. Just make sure it goes to adequate length, it's not too wide, and also you're able to bond it in. And for me, It's the bonding the post in place predictably. That is one of the most important stages. And I know I've asked you this before, but always read the manufacturer's guidelines when it comes to your bonding protocols, or understand what materials you're using, because sometimes we don't follow what the manufacturer says, and normally there's an error in process there.
Sure. And in your opinion, is there any preference that you have between tapered posts and non-tapered posts?
Well, Ricketts et al. 2005 preferred using a parallel-sided post. Again, look, if you're going to use a parallel-sided post or a tapered post, with a parallel-sided post, that's my go-to. I use fiber post by Colteam, okay, the Parapost system. I'm still looking to not use an excessively wide post, one that passively fits within the canal, because all I'm doing is increasing my surface area to bond to. I am not imparting strength to the tooth by placing a post. We're weakening the tooth. So all I'm doing is increasing my surface area to bond to. So for me, I use parallel-sided posts most of the time. There is on occasions that I will use a tapered post. The tapered post that I use, again, Parapost Taper Lux. With the Parapost Taper Lux, the only situations that I consider them or using tapered posts are in narrow teeth. So for me, my narrow teeth are my lower incisors and my upper lateral incisors. Why? Because I don't want to remove too much dentine when teeth are narrowing. And I do not want to risk perforation at any point in time. So those are the only occasions that I really get the tapered posts out. The disadvantage of tapered posts is they'll concentrate stress. And we want to reduce the stress on a tooth to make sure it can take the functional load.
And do you plan your fiber posts any different to your cast posts?
Good questions though. With that, I think fundamentally they're retained in very different ways. With a cast post, you're looking at mechanical retention. And if you're looking at mechanical retention, then the older philosophies and theories apply, whereby you would try and make sure the length of the post is 2/3 of your estimated length from your coronal reference point to your apex of your tooth, because you're relying on retention being achieved by increasing your length of the post. Whereas with fiber posts, they're treated very differently. So with fiber posts, we're relying on increasing the surface area that we're bonding to, and you are relying on adhesion with the fiber post rather than just mechanical retention. So we don't need to place as long posts as we used to. And even if you place the fiber post to within half of your estimated length, you are increasing the surface area that you're bonding to significantly. And if you can be strict with your bonding protocols, you get a predictable end result. Whereas everything for me is identifying errors in process. I will eliminate any errors that I have. So with the fiber post, my bonding protocols, although I'm only going to half the length, my bonding protocols are very stringent. And that way, most of my cases are fiber posts now.
And do you have a perforation prevention protocol?
It fundamentally comes down to planning. Okay, if there's one thing I will teach all of you guys is make sure you plan your cases. If I know how far I have to go with my post and what depth I'm placing it, I know how wide a post I'm going to place, and I know that there is enough tooth all the way around and I'm placing it in the right direction, I'm going to be a very happy dentist. And if you plan all of those things beforehand, the procedure is relatively straightforward. For me, although I may not have time to go through the whole protocol with you today, for me, make sure that as you're going up in sizes, create a path for your Parapost drills or whichever drill system you use. So for me, I use Gates Gliddens if I've got to remove GP, because in essence, like your hand files, before you use rotary files, you should always use hand files. Before you use any post drills, use your Gates Gliddens. They will effectively create a path for the post drills to follow. Anytime you feel a stop and you're not to the length you want, there are only two things and that could have occurred. One, you're going in the wrong direction, or two, there's debris within the canal. How do you assess that? Stop. If something is not going where you want it to and you're feeling resistance, the key is not to push harder, it's to come back out. So for me, if you felt any resistance and you're not to the length you want, stop, reassess. For me, irrigate the canal out with lots and lots and lots of saline, or if you're using distilled water, that's okay as well. Once you've done that, you can then assess if you're going in the right direction by taking your drill off of the handpiece, putting it in the canal and seeing if it's drilling in the same direction as where you want it to go originally. Those are not the whole protocol, but mini summarized version.
Right. So we've covered all the theory. Let's move on to a case. Can you talk us through this one?
Yeah, of course. So this is one of my patients that came and saw me. Her original philosophy was she didn't believe in saving teeth and she wanted to just have implants. We gave her a treatment plan for the cost of implants. She decided we were too expensive and decided she was going to go to Eastern Europe, have a few implants placed. They started to fail, some of which survived. And you can see that in the picture, there is actually a couple of stitches in there where she had a couple of implants removed and bone grafting. Suddenly, she changed her philosophy and she believes in preserving teeth, and she wanted me to do anything and everything to save this tooth. We talked a lot about pre-treatment evaluation earlier on, so I'm going to just go through this quickly because I think if you plan, you're going to get a predictable end outcome. So for me, when I'm looking at this sort of case, the first thing we talked about was endodontic status. So let's go through that. In this case, you can see that there is a root filling already in there. So we're looking at, was this patient symptomatic? There's no clinical signs and symptoms at all. 2, radiographic appearance. Well, looking at the x-ray, it looks like a pretty good endo. Like, it's not too far away. There's no large apical pathosis there, but evidence of potential apical pathosis. But more importantly, the GP is also exposed in the mouth. For me, if there's GP exposure, think biologically first. If GP is exposed, there's bacteria in the canal system. Build a house on solid foundation. So for me, that's a retreatment. Periodontally, which is our next thing that we assess, looking at this case again, she was actually very, very tooth aware. So actually her cleaning was very good. Most areas 2-3. In aesthetic areas, be careful of gingival biotype. We missed this earlier on. A thin gingival biotype, gums are more likely to recede if you get things wrong. Or a thick gingival biotype, you might get chronic inflammation there. In this patient, I'd say she was more thin gingival biotype than thick, but I'm not too worried about gingival recession here because I think her aesthetic needs, looking at the crowns that she had placed, were not very high. So that was pleasing for me. If we look at the alveolar crest, there is a lot of root supporting the final restoration. So the crown to root ratios here are favorable. And then finally, looking at biomechanical evaluation, because we've talked about aesthetics. Biomechanically, looking at it, we talked about the ferrule, okay, or the ferrule effect. Ideally, you should have 1.5 to 2 millimeters of tooth all the way around the tooth. And having a look at this pre-op image, you can clearly see that we did have that all the way around. If I've got a ferrule, I'm going to be placing a fiber post there, so I'm happy. Everything here is telling me this is predictable dentistry, which means I'm happy to proceed with re-RCT, post and core, and crown. Crown, luckily for me, is done by a prosthodontist. So the other thing when we look at biomechanical evaluation is controlling the forces that are placed on the tooth. That would be planned before we restored the tooth. So happy with that. The procedure itself, how do I remove GP? Okay, for me, I will begin to remove GP with a Gates Glidden, create a glide path, and then I like reciproc blue. Okay, it's just a personal preference. Everyone has their own system that they like. That helps to remove the GP from within the canal system. Once I've got the GP out, or we're getting close, we need to determine the working length. For me, my go-to is obviously my apex locator. That can most accurately determine where the canal finishes. And once we've got that, we would then work down to the correct size, mechanically prepare using our file systems that we use. For me, again, this was a reciproc blue case, and then we can dry the canal prior to taking a master cone radiograph and finishing off the case. Because I use heated GP, I am fortunate enough by using heated GP, I just burn the GP off to the level where I'm going to place the post. So in this case, the GP was melted down using the System B, and you can see the image clearly there where the GP was filled till. We then passively placed a post within the canal system. In this case, it only required a little further preparation to make sure of smooth placement. And for me, planning a post is the most important thing. I need to know how long a post I want to place. I want to know how wide a post I can potentially place. And remember, the golden rule is to preserve as much quality and quantity of tooth structure. So I am trying to place a post as passively as I can to the ideal length, which usually is quoted for fiber posts as half the root canal length or within 5 millimeters of the radiographic apex. We don't want to go any further than that. Once we've done that, it's as simple as preparing it with your post drills. Once prepared with your post drills, I would always, especially early on in your careers, take check x-rays with the post in place to make sure it's appropriately directed and to the correct length. Once I've done that, I'm happy. And then it fundamentally comes down to your bonding protocols. I do not mind which system you use. Okay, so long as you understand the criteria of how it likes to be bonded in place. Paracore by Coltine is a good product. For this case, I think I use Panavia V5 to bond the post in place, because there's some research out there that shows actually using a silane coupling agent on your post can increase your bond strengths. So I want to bond as predictably as I can. From that point on, it's as easy as doing your core build-up. And for me, my core build-up's something composite. Final restoration for this case was not in my hands. It was in the hands of a prosthodontist. So I am glad that I do the endo and someone else can do the resto.
Thank you. And what are the key points you want our viewers to take from today?
For me, pre-treatment evaluation. Okay, the pre-treatment evaluation is the key to success. Plan your processes. And then during the treatment, actually just having the mindset and understanding that no post is the best post. Okay, I know this is restoration of the root-filled tooth, but understand that if we can bond to the tooth. Don't place a post when it's not needed. And know if I'm gonna place a post, what do I need to do?
Perfect, thank you. And how can our viewers find out more about your work, training, and courses?
evoendo.co.uk is shortly due to go live at the end of June. And also Instagram, Dr.Didge_EvoEndo is a great way of you seeing my cases. And if you guys have any questions, look, I'm always here to inspire people to learn and grow. So for me, if you've got any questions, you can direct message me on Instagram.
Perfect. Thank you so much for coming on to our YouTube channel today, Dr. Didge. We've learned so much from you today. And thank you guys for watching.